following are indication of supracondylar transhumeral amputation. We are marking the posterior skin flap. It will start from the skin which is intact below the supracondyle of the humerus. Now the anterior skin flap is marked by keeping 2 cm above the posterior skin flap. Anterior skin flap is made contains the muscle of bicep and brachialis muscle. The posterior skin flap is being made while the posterior skin flap also contains the cushion of tricep muscle. After markings preoperatively, we have incised the skin for anterior skin flap by cutting the subcutaneous tissue. Now a posterior skin flap is being made from going lateral to the medial side. We can say by going from posterior medial to posterior lateral of the arm. The posterior skin flap is 2 cm longer than the anterior skin flap. It will shift the line of tension away from the bone. The posterior skin flap is being created by incising with a scalpel, keeping it at right angle to the skin, and we're cutting the skin and subcutaneous tissue with belly of the scalpel. Be careful while cutting the subcutaneous tissue because the main veins run in subcutaneous space. We are going bit by bit from posterior medial to posterior lateral of the arm. The subcutaneous tissue is being divided. Place artery where you suspect that some kind of vessel run in the area to be divided. Now keep the width of subcutaneous tissue depends upon the accumulation of subcutaneous fat. Person who have a high BMI have higher content of fat in their body as compared to those who have low BMI. Now we have reached the tricep muscle. You can appreciate the whitish fibers of the triceps tendon. It is being cut with the help of blade. Cautery can also be used to avoid any spurting of bleeding vessels during the procedure. Fibers of tricep muscle are being cut with the help of diathermy. It will coagulate and cut at the same time. Now the middle side of tricep is being divided. The ulnar nerve is identified and is cut with the help of diathermy. Because ulnar nerve is a large nerve, it contains the vasa nervorum, that are the small branches supplying blood to the nerve. It runs in the perineurium. Now we are cutting the anterior skin flap. We are going deep below the subcutaneous tissue, above the fascia of the arm. We can appreciate a long vein running in subcutaneous tissue. This vein is known as the basilic vein. It is bluish in color with a thin lumen. We will make it ligate with a non-absorbable suture, particularly silk is used. Try to tie both ends of the vessel at the same time, first proximally and then distally, to avoid any spillage of blood that will handle the procedure. Now the vein has been ligated, and make sure that knots are completely fitted, otherwise post-operative any slippage of the ligature could lead to the formation of primary hemorrhage, as post-operative slippage of the ligature is particularly the main cause of primary hemorrhage. Now we are insecting the medial intermuscular septum. The medial intermuscular septum runs between the anterior and the posterior compartment of the arm. The intermuscular septum has been separated, and you can appreciate the red belly of bicep brachii muscle, the main muscle running in the anterior compartment of arm. It originates with two heads from the clavicle and glenoid to the radial head. Fibers of the muscle are always divided slowly and timely to prevent the post-operative bleeding. We are going bit by bit by taking few fibers on the Kelly artery forceps to prevent any damage to the main vessel. The only main vessel running in the arm is the brachial artery that will lie in the lower end of the arm medial to the bicep brachii tendon. Now we have appreciated the median nerve that will lie immediately medial to the artery. The nerve has been ligated and cut. Now we are dissecting the brachial artery from the fascia. It had been dissected with a Kelly artery forceps and ligated it proximally and distally on both ends with vicryl suture, then ultimately with non-absorbable silk suture. We have ligated with vicryl to prevent any slippage during the procedure or post-operatively. You can ligate it only a single time with non-absorbable silk suture. The remaining fibers of the fascia and the bicep tendon are being divided. You can appreciate the muscle fibers running longitudinally above to downward, lateral to the brachial artery. We are making sure that the muscle fibers are cut continentally only at the point where cautery or you can say the diathermy touch. The cautery is always kept in a controlled fashion to prevent any damage to the underlying structure. Always see the tip of the cautery while dissecting any tissue. If it is skin, subcutaneous tissue, muscle fibers, or any other structures, for example, in the abdomen, the mesentery, or the bowel loops. Posterior muscle fibers of the bicep brachii have been cut and divided with the help of diathermy. Bicep is the flexor of forearm. The prime mover of the forearm is brachialis muscle that runs from the mid of humerus to the radius. Now we are dissecting the posterior brachial artery. Is a continuation of the axillary artery below the teres major muscle. It continues down the anteromedial of the arm and reaches the cubital fossa at the radial head, where it divides into the ulnar and radial arteries. When it gets thrombosed, it will lead to the ischemia of the forearm and the hand. If collaterals are developed, then patient can survive the limb. Otherwise, it needs to get embolectomy, or the alternative is amputation of the arm. Now, we have separated the periosteum from the bone to prevent postoperative pain. Now cut the bone with help of giggle saw. You can see we are using giggle saw. It is held at right angle to each other, making a sharp and brisk and continuous sawing movements to cut the bone. Be steady, otherwise you could lead to the breakage of this giggle saw, because it is not so much hard, it is flexible, so hold it with care. And it also has bleeding margins, so not to touch it during its sawing movements, otherwise you can accidentally damage your fingers or hands, leading to